Good afternoon, everybody. Thank you for joining me on your lunch hour or your lunch half hour. I've been asked to talk about understanding genetic risk factors for cancer, which is a huge topic and not one that we can necessarily cover in full in 30 minutes. But I decided to focus on three types of cancer that we know a lot about in terms of genetics. So we'll talk about hereditary breast, ovarian, and colon cancer and what we know about some of the genes related to those three cancers, and we'll also talk about genetic counseling, what it is that I do and what role that plays in genetic testing and understanding genetic risk factors. So what do we know about the risk factors for breast cancer? Well, we know that there are several, but what we're going to focus on today is family history. And like with breast cancer, ovarian cancer has several risk factors, and we'll also focus today on family history and what that means. And colon cancer also has multiple different risk factors, but we'll also focus on family history as well. So how much breast and ovarian cancer is actually hereditary? And what do we mean by hereditary? Hereditary breast and ovarian cancer, or any cancer in general, essentially means that in a gene that everybody has, in a very rare individual from a very rare family, there is a change in the genetic material of that particular gene that causes it not to function correctly. And that gene ultimately is passed down in the family and can lead to the cancer susceptibility that we specifically see in these hereditary families. Interestingly, though, most cancer in general is not hereditary, and probably 5 to 10% of all cases of breast cancer diagnosed every year are actually due to a breast cancer susceptibility gene that's not functioning correctly. And as with breast cancer, the majority of ovarian cancer is actually not hereditary. Probably, again, about 5 to 10% of all cases are due to a gene that's not functioning correctly. And like with breast and ovarian cancer, colon cancer is also, colon cancer, most colon cancer is also not hereditary as well. Probably 2 to 3% of all cases of colon cancer are due to a gene that's not functioning correctly. So what do we know about breast cancer susceptibility genes? So if you think about it, we all have about 20,000 different genes. We have 2 copies of every gene, one from mom and one from dad. And at this point in time, we probably know about 20 different genes out of the 20,000 that when one of them isn't working correctly, leads to a susceptibility to develop breast cancer. Probably most of you, if you know a little bit about this, have heard about the BRCA genes, BRCA1 and BRCA2. Those are the 2 genes that we know the most about when it comes to breast cancer susceptibility, but you can see from this slide that there are multiple other genes as well. Some of them, when they're not working correctly, can confer an extremely high risk for breast cancer, like with BRCA1 and 2, a lifetime risk of somewhere between 45 and 85%. And when you compare that to the general population risk, which is somewhere around 12%, you can see that that's pretty significant, and those women have to be followed much differently. We have moderate risk genes for breast cancer also, where the risk is not as high as it is for the high risk genes, but still much higher than in the general population. And then we have some newer genes that you can see all the way to the right, where we know that they play a role in breast cancer susceptibility, but we don't have as much information yet because we haven't been studying them as long as we've been studying the other genes. With ovarian cancer, we have multiple ovarian cancer susceptibility genes as well. There's about 24 of those that we've identified at this point in time, actually 25 now. And you can see from this slide, what's interesting is that BRCA1 and BRCA2, although they're breast cancer susceptibility genes, also play a role in increasing someone's risk for ovarian cancer as well. And not everybody, when they come to see us, realize that that's actually the case. So just like with the other slide, this just gives you an idea of the genes and the number of genes that we now know about that play a role in ovarian cancer susceptibility. Again, with BRCA1 and BRCA2 being the major genes that we know the most about, but there are several other genes as well that can confer an extremely high risk for ovarian cancer, anywhere from 10 to 60%. And actually 5 of those high-risk genes are actually considered to be colorectal and uterine cancer susceptibility genes as well. And then we have some other genes that we've identified that confer a more moderate risk, maybe around 5 to 7%. You know, the average risk in the general population for someone to develop ovarian cancer is less than 1%. So these risks are pretty high, and these women also need to be followed a little bit differently. And also there are some newer genes now that we're starting to learn more about. And that's one of the things about genetics, is it's kind of a field that's always in flux. Things are always changing, and we always have new information. Just like with breast and ovarian cancer, there are several colorectal cancer susceptibility genes. Probably at this point, we know about 18 or 19 different genes, with some of them conferring extremely high risks, like you can see all the way to the left. Then we have more moderate risk genes, and then newer genes that we're learning more about. We frequently see people who come to us with family histories of colon cancer that look like they may be hereditary, and when we do genetic testing, we don't find that any of the genes that we know about are not functioning correctly. So in those cases, a lot of times it means maybe the gene just hasn't been found yet. So those folks we keep in contact with as we learn more and more about the genetics of colon cancer. So you might be thinking about your own family and thinking, if there is a family history of breast cancer, what's the likelihood maybe that I have a BRCA1 or 2 gene that doesn't work, or maybe another gene? So these are some of the things that we look at when we're trying to assess what somebody's likelihood is of having a particular change in a gene. Are there multiple breast cancers on the same side of the family in many generations? Is there breast and ovarian cancer in one woman in the family, or in more than one woman? How old were the individuals when they were diagnosed? Were they less than 50? Is there a woman in the family that maybe had 2 breast cancers in one breast, or bilateral breast cancer, or breast cancer in the left and the right? Is there male breast cancer in the family? Is there just ovarian cancer in the family? Is there pancreas cancer in the family? Interestingly, we're learning more and more about the genetics of pancreas cancer as well. And we know that there are also multiple genes that are responsible for hereditary pancreas cancer, with BRCA1 and 2 actually being 2 of those genes. So if you have a family history of pancreas cancer alone, or in the setting of breast and ovarian cancer, or maybe colon cancer, that would be a family where genetic counseling and possibly testing would be appropriate. Prostate cancer also, we see those in BRCA1 and 2 families. We're learning more and more also about the genetics of prostate cancer and the genes possibly related to hereditary prostate cancer. So even just a family history of prostate cancer with no family history of any other kind may be a family or an individual that's appropriate for genetic counseling and testing. And you also may have heard about whether or not somebody is of Ashkenazi or Eastern European Jewish ancestry, maybe being at an elevated risk for breast cancer. The reason that we ask about that is because the genetic changes that we look for in genes, sometimes in BRCA1 and 2, that are more common, and may, just because of ethnicity, be a reason to consider genetic counseling and testing. So just like with the breast cancer susceptibility genes, these are some of the questions we ask if potentially somebody might have a hereditary family history consistent with a change in an ovarian cancer susceptibility gene. So some of the same questions are asked. Is there breast cancer in the family? How old were the individuals when they were diagnosed? Did somebody have multiple breast cancers or bilateral breast cancer? Is there male breast cancer, ovarian cancer? Again, pancreas cancer, prostate cancer. Is there uterine or endometrial cancer in a family diagnosed less than 50? Is there uterine or endometrial cancer at any age in the setting of a family history of colon cancer or uterine cancer or ovarian or even breast cancer? Colorectal cancer, under the age of 45, and then a family history again of multiple different kinds of cancer as well. What about colon cancer? What do we look for when we're trying to figure out if somebody's appropriate for genetic counseling or testing? And just like with breast cancer or ovarian cancer, are there multiple colorectal cancers on the same side of the family? Were any or some of the individuals younger when they were diagnosed, less than 45? Did somebody develop two distinct primary colorectal cancers, either at the same time or at different times in their lives? Does somebody have uterine or endometrial cancer alone, diagnosed at age 50, even without a family history? And again, is there a cluster of cancers where we see colorectal, uterine, ovarian, pancreas, even urinary cancers? What about the person who's been found to have multiple adenomas on a colonoscopy, or a family history of relatives with multiple adenomas on a colonoscopy? That may be somebody that's also appropriate for genetic counseling and maybe genetic testing. And then what kind of polyps did they have? And ultimately that information will be on the surgical pathology report that whoever did the colonoscopy will ultimately get. And sometimes the pathology may indicate that a person may be appropriate for genetic counseling or testing. So for those of you that maybe have a family history of breast cancer, these are some of the things that we often hear about, some of the things that are not always understood when people come to see us. Often we'll hear breast cancer doesn't count if it's on the father's side of the family, it's only if it's on the mom's side. And that's actually not true, because half of all women with hereditary breast cancer inherit it from their father. Ovarian cancer in the family is not a factor in breast cancer risk. Well, you can, obviously from what I've been saying so far, they tend to go together. So ovarian cancer and breast cancer can sometimes indicate a risk for the one or the other cancer. And the most important thing in the family is the number of women, which actually isn't true. It's more the age of onset. That's more important than actually the number of women that have been diagnosed. So when folks come to see us, we sit down and we talk about medical history, but the big thing is the family history. The family history is really the tool of the geneticist and the genetic counselor, and it really helps us to make at least a preliminary assessment of what may or may not be going on. So what we do is we draw out what we call a pedigree, this diagram here with the circles and the squares. We ask about the maternal and the paternal side of the family, and we go back 3 generations and kind of ask what kind of cancer is in the family, how old were the individuals when they were diagnosed, what kind of treatment did people have, are you aware if anybody had genetic testing, and inevitably anybody that you talk to is going to have some kind of family history of cancer, but it's going to be that very rare family where the history that you see is actually going to be one that's hereditary. Now, certainly our family history is limited by what people know, and if they don't know their family history, then certainly the pedigree is not going to be as helpful. But for us, it's kind of the first step. So if you look at the family history on the left, you can see that that is more than likely a hereditary one, because there are 2 sisters who were diagnosed with breast cancer at early ages. And then they also had a paternal grandmother who was diagnosed with ovarian cancer at 52. So that would be a family that is obviously one that we would want to look at a little bit closer, and has certainly an increased probability of having either breast or ovarian cancer susceptibility gene explaining the history that we see. The family history on the right side is one where, yeah, there's definitely a family history there. There's an individual on one side of the family who was diagnosed with breast cancer at 71, and then on the other side of the family, someone diagnosed with breast cancer at 63. So those 2 cancers are not related to each other, but are certainly ones where we wouldn't consider them to be hereditary simply because of their ages of diagnosis. We have seen families certainly where there are older breast cancers in a family where we've identified a gene that's not working correctly. It certainly does happen, but it usually doesn't express itself this way, where this is all that we see. So individuals in this family will certainly have a higher risk, but not a hereditary risk to develop breast cancer. So I know we've been talking a lot about BRCA1 and 2. It's because those are the families and those are the genes we know the most about. We've been doing genetic testing for those genes since the early 1990s. And the amount of information that we have that can be helpful to a patient, either with a family history or with a diagnosis of cancer, is incredible. But we do know that there are other genes, and we often find other genes that explain family histories that look hereditary, and this is an example of one. You can see where there's an individual who was diagnosed with breast cancer at 56 and 72, and she had a mom who was diagnosed with breast cancer at 65, and then a cousin who was 57. And the interesting thing about this family, why we looked at it closer, was because of the family history, and then also the fact that she went on to develop a second breast cancer several years later. She had had genetic testing for BRCA1 and 2 and was negative, and then recently found out that she actually has another breast cancer susceptibility gene that's not working correctly called PALB2. So that information certainly is useful for her, because we also know that in those families we can sometimes see pancreas cancer. So the discussion about whether or not to do screening for pancreas cancer is important for her. She's got a brother who also has 3 daughters. She's got a son. So now this information can be helpful for them should they decide to have genetic testing. Okay. So I know we've been talking a lot about breast and ovarian cancer. So here's an example of a family history of hereditary colorectal cancer. Some of you may have heard about a syndrome called Lynch syndrome. It's actually named after the doctor who started studying these families. And the interesting thing is that Lynch syndrome is considered to be a colorectal cancer susceptibility syndrome, but we also see a variety of different kinds of cancer in these families. So if you think about your own family and think about maybe if it possibly looks something like this, the circle of the woman who's 36 had a sister who had uterine cancer at 49. Her aunt had pancreas cancer at 65. Another aunt had uterine cancer at 51. Then we also see bladder cancer and colon cancer in the generation above. And she was interested in finding out, interestingly, what was her risk for uterine cancer because her sister had it. And the rest of the family history we sort of figured out and found out about later. But ultimately, her father, who's the square with the yellow line going through it, had genetic testing where we looked for the 5 genes that are responsible for Lynch syndrome, and he ultimately was found to have an MSH2 gene that didn't function correctly. And then ultimately, his daughter who had uterine cancer had genetic testing for the same thing, and she was found to have it. But our patient who's 36 who had genetic testing, we found out that she did not. So that was information, obviously, that was welcome to her, useful for her, because now we know that she doesn't have the high risk to develop colon cancer or uterine cancer, pancreas cancer, bladder cancer. So she doesn't need to do all the additional screening that comes along with having this particular colorectal cancer susceptibility gene. So just to give you a little background quickly on chromosomes and genes and what we're doing when we do genetic testing. You know, you have a cell, every cell has a nucleus, that's where the chromosomes are located, and then the genes are actually sitting on the chromosomes. So every gene makes a protein, and it's actually the protein that does the job of the gene in the cells of our body. So when we do genetic testing, what we're doing is looking to see if there are any changes in the genetic material that make up the gene that would cause it not to do its job correctly. So in the diagram on the right, that particular gene makes a functional protein, but on the right, on the left, excuse me, on the right, that particular gene has a mutation in it and it makes a protein that doesn't work correctly, and that's what leads to the susceptibility to develop cancer. So what we know is cancer arises from mutations. In the hereditary situation, the mutations are actually in the sperm and the egg so that they can be passed on. They're in every single cell in a person's body. But for the majority of people who develop cancer, they only have mutations in genes within the tumor itself. So it's not something that they can pass on. So we call those somatic mutations. And the ones that we can pass on are called germline mutations. So that's the difference. So just to give you kind of a really quick overview of how this information can be used in a specific setting. We talked a lot about BRCA 1 and 2, but it's probably a good idea for me to go through all this because this is what we know the most about. So this particular diagram is what we call a karyotype, and it has all 23 pairs of chromosomes on it. And on chromosome 17 is where BRCA1 is located, and BRCA2 is on chromosome 13. And I always like to include this because I think it's just a really cool depiction of what chromosomes look like. So this particular slide, just to go over again why being of Ashkenazi Jewish ancestry is significant, at least with BRCA1 and 2, is because in the BRCA1 gene located on the top, there are 2 changes within BRCA1 and 2, or mutations we call them, that are common if you are of Eastern European Jewish ancestry, and in BRCA2 there's 1. That's common. So if someone comes to us and has a family history that looks like it might be hereditary breast or hereditary breast and ovarian cancer, and they happen to be of Jewish ancestry, usually one of these 3 particular changes will explain that history, but not always. So what do we know? So in the setting of somebody who actually has a BRCA1 mutation that doesn't work, women have anywhere from a 50 to 85% lifetime risk to develop breast cancer. If she's already developed breast cancer, she has a 40 to 60% chance to develop a second breast cancer in her lifetime, and also a risk to develop ovarian cancer. And like with BRCA1, we also see similar numbers with BRCA2. But also, there appears to be a much higher risk for male breast cancer with BRCA2 than with BRCA1. So we also can see some risks for other kinds of cancer, and this is also important that for folks to know when they undergo genetic testing, that it may be that they just have a family history of breast cancer and that history looks hereditary, but there are other cancers that they might be at risk for, whether those cancers are in the family or not. So like we said before, we can see male breast cancer, we can see prostate cancer, pancreatic cancer, and even melanoma. So all of these things need to be screened for in a different way in somebody who's found to have a hereditary cancer risk. What has been interesting about the evolution of the information that we know about BRCA1 and BRCA2 is that it has implications for women who have already been diagnosed with breast cancer. We didn't always have this information, and now we do. So we know that these women have a higher lifetime risk to develop ovarian cancer following a breast cancer diagnosis, and like I said before, an increased risk to develop a second breast cancer after the first. So this information comes into play at the time that somebody is diagnosed with breast cancer in discussions with their breast surgeons. We also have to talk about how to manage all of the other risks. So certainly in a woman who doesn't have a breast cancer diagnosis but has a family history and had genetic testing, the way she's ultimately followed going forward changes. So your average woman, usually around the age of 40, will get her first mammogram. Women who are shown to have either a BRCA1 or 2 mutation usually start around the age of 25, and then they also do breast MRIs as well. So usually they're doing something every 6 months, and obviously they're starting to do it much earlier than someone in the general population. Sometimes risk-reducing surgery is discussed, prophylactic mastectomy to reduce the risk for breast cancer. It's not a recommendation, but it's an option of something to consider. And for some women, it's the right thing to do, and for some women, it isn't. And for those that don't pursue prophylactic mastectomy, the imaging is how they're followed going forward. Oophorectomy is ultimately something that is recommended because of the elevated risk for ovarian cancer and because we don't have a really ideal way to screen for ovarian cancer. But usually the surgery happens, or it starts to be talked about, usually in the 40s, after a woman has made decisions about childbearing, whether or not she wants to have children or not have children. It's not something that is recommended when someone's 25 years old. And then there's chemoprevention to decrease the risk, medicines that somebody can take and consider, something like tamoxifen or even oral contraceptives to decrease the risk for ovarian cancer. And all of those things are conversations that women have with their medical oncologists, with their gynecologists in detail. So what about men who are found to be at increased risk for breast cancer? It's not entirely clear how to follow these men, but usually what's ultimately recommended is that they see a breast surgeon or their primary care doc and get a clinical breast exam, that they do their own breast exam, and that they consider mammography around the age of 40. Prostate cancer screening is also something that's recommended around the age of 40, as well as for men and women, colon cancer screening, going to the dermatologist to be screened for melanoma, and then ultimately screening for pancreas cancer, which is also an area where we're doing a lot of research, and it's not entirely clear how to follow people who are at increased risk for pancreas cancer. But most of the patients that we see ultimately are seen as part of big research programs, either at Mount Sinai or in other institutions in the city that are looking specifically at patients at high risk and how to screen them. So one of the things that is newer now is that once a woman is diagnosed with breast cancer, if she has a family history or if she's diagnosed at an early age, genetic testing for BRCA 1 and 2 is something that's becoming part of the workup. So for those patients, it can help inform what kind of surgery they do. If it's determined that they need chemotherapy, it may determine what kind of chemo regimen or whether hormonal therapy is appropriate. And then obviously handling the additional risk for breast cancer and ovarian cancer, and then talking about how ultimately all of this has implications for relatives. So it's a lot of information on top of just being diagnosed with breast cancer, but it's also very important information to have and helps out all the folks that are trying to take care of these patients when they're diagnosed. So what's the status of genetic testing in 2020? So in general, if someone decides they want to do genetic testing, we either take a blood sample, a spit sample, or a saliva sample. We can use other tissue as well. Testing costs are usually covered by health insurance, at least partially, and it's kind of moving towards at least partially to mostly covered, especially if you meet the guidelines for genetic testing. There are laws to prevent discrimination in health and employment, which was more of a big issue early on in the 1990s when we weren't sure exactly how this information was going to be viewed. But there is a federal law, and pretty much every state has a law governing what insurance companies and employers can do with this information. Testing, like I said, is often offered at the time of diagnosis because it can be helpful, and access to genetic testing and autonomy are very important. So just to give you an idea about what I do when I sit down with a patient and talk about genetic testing, we go over, the medical history, why someone is actually being referred, what they think their risk is. We talk about basic genetics. We talk about the risks and the benefits and how the testing is done. If they decide not to do testing, what are the alternatives? And then we talk about if they're positive or they're negative, how they would be followed going forward. And benefits really are improved cancer risk management, can provide relief from uncertainty and anxiety about cancer. We can provide information for the person sitting in front of us and their family members and help them to make decisions about lifestyle going forward. Certainly there are risks associated with genetic testing, and certainly it's distress and anxiety, loss of privacy, concern about discrimination, changes in family dynamics, especially when there are individuals who test positive for a specific gene not working and others who don't, and how that changes their relationship. A false sense of security if you test negative. The biggest thing that we make sure that we get across is even if there is a gene identified in the family and you don't have it, you still have a risk for cancer. Your risk is never zero. So what are the limitations? Certainly when we do genetic testing and we look at multiple different genes and we don't find that somebody actually has a change in a gene, it doesn't mean that there's not another gene we haven't found or that technology hasn't picked up a specific change in a gene in a specific family. Sometimes we find changes and we don't know what they mean, so we have to talk about that. A negative result only means something if we've already identified a change in a family. And then again, the results indicate a probability of getting cancer, so not a certainty. So all of this is done once we get the results. It's a multi-step process. We talk to the patients ahead of time about how they want to get the results. Do they want to get them by phone? Do they want their breast surgeon to disclose the information? Do they want to come in? Do they want the results to go to their husband and then their husband talk to them? This happens. Tell them how we're going to maintain the confidentiality and privacy of the information, who they want the information to go to. Like I said, we disclose the results however an individual wants, kind of assess how they're feeling with the information, and then discuss their plans for follow-up, and then, of course, include their physicians in the results once we get them. So at the end, we just follow up with patients to see how they're doing with the information. We review the meaning of the result. And then discuss how they're going to share the results with their family, and then discuss the medical follow-up plan. So genetic testing sometimes is referred to as just a blood test, and it is, but there's just so much more that goes along with it, and you just have to make sure that you're getting all the information about the test before you actually decide to do it, so that you know what the risks and benefits and the limitations are. And if anyone's interested in genetic counseling or getting more information about testing or making an appointment, we have a cancer genetics program at Valley, and I am one of 3. And for some reason, I forgot to change this slide, but there are 2 other genetic counselors who are fabulous that work with me, Zipporah Eckstein and Rachel Segalski. And if you are interested in making an appointment or learning more, you can call that number and we'll set you up. Phew.
Right. Thank you. Thank you, Mary Kay. And we're just going to answer a few questions that people have put in here. So one of them is, I'm a female and my father had prostate cancer 20 years ago. He was diagnosed and had surgery at age 60. Is there a need for concern?
So if there is any other family history of cancer, we would like to know about that. But his diagnosis alone may be enough for you and he to consider genetic counseling with me not knowing anything about the pathology of his prostate cancer. So not necessarily concern, but he may be appropriate for genetic counseling.
As well as herself, right?
Yes, yeah.
Okay, perfect. So, and then there's another question. If I'm already negative on the genetic genes, which she had tested negative, is there still a genetic factor for breast cancer, which she had breast cancer as well, and I guess tested negative?
Okay. So it would depend on your family history and how old you were when you were diagnosed and what genes you actually had testing for and when. because it may be that there are some newer genes that you maybe didn't have testing for yet that might be appropriate to look at. But if you had genetic testing recently and they looked at all of the genes that we can actually test for and you were negative, can't necessarily say that there's no genetic factor because there may be another gene that we haven't found yet. But at that point, we've ruled out everything that we know about.
So for somebody who has several family members that have different types of cancer and had been tested for, had done genetic testing, how often should they get retested?
So what we tell everybody in that situation is to check in with the person who actually ordered your testing every year or two to see if there's anything new that might be appropriate for you to be tested for.
And then is there a different type of risk if your family members either test for the same cancer all the time, like get the same type, let's say breast cancer, versus a cluster of different cancers? Is there a different risk for that for that person?
So it's kind of a hard question to answer because you have to sort of assess every family individually. But we know a lot about hereditary breast cancer, and the family where there are multiple different kinds of cancer, we would need to look at specifically to see if what maybe they have in common is another gene that might explain all the other different kinds of cancer that are in the family.
Okay. My sister had ovarian cancer when she was in her early 40s. No one else in the family. There's 2 other sisters that has had cancer. I'm the youngest sister at 70 and have no children. And my sister's children are all older, 35 and above. Is there any point for me to test at 70?
So your sister who had ovarian cancer would be the most appropriate person to have genetic testing if that's possible. Anybody that has a family history of ovarian cancer and a close relative is appropriate for genetic counseling and genetic testing. So the daughters of or your nieces of your sister and even you would be appropriate because it may, even at age 70, change how you're followed going forward if you still have your ovaries.
So I think you mentioned your contact information is above. Mm-hmm. And to make an appointment is just by calling, I guess.
Yeah.
But what's the, how does it usually work? Do they need a consult or, I mean, a prescription from the physician, or can they just contact you directly? And how do you go about the whole process?
So it can be either way. You can call that number directly and just make an appointment. We need obviously a physician, either a primary care physician or a GYN's name for us to contact if we need to report back with information. Within the Valley system, a lot of the OBGYNs and primary care physicians just send a referral electronically directly to us, and then we call the patient directly to make the appointment. Because of COVID, we are doing all of our consults virtually, mostly by phone. And then ultimately, if a patient decides that they want to have genetic testing, they come in to see us to give the blood sample.
Perfect. Well, is there anything else you would like to add, Mary, before I finish our presentation?
I think I talked enough.
You covered so many topics. It was so informative. Thank you so